All right, I'm back. Had to go pick up my son from school. So, picking up from where we left off, we are talking about nursing medical care for patients with ventilators. So, we want to make sure every start of shift, we're reviewing the settings. So, like I said earlier, we're talking about every intervention requires removing that intervention. So maybe we can change the settings to a lower setting to start weaning the patient off. Let's make sure that the settings haven't changed, that they're not too evasive for the patient and causing negative side effects. Make sure we're performing suctioning. So if they're being ventilated through a trach or an ET tube, make sure we're performing suctioning of that to remove any of those secretions to prevent any high pressure or low pressure alarms. Checking for pain and sedation. So we're going to give. I just want to go into sedation really quick. When we're talking about doing rapid sequence intubation or RSI, it's a little bit of an inappropriate way to remember etomidate before succinate. So a little not safe for work here, but we always date before we suck. So that's a good way to remember etomidate before succinate. Um, we're also going to make sure we're looking out for ventilator-acquired pneumonia. So make sure we're doing proper positioning, 30 to 45 degrees. Make sure you're looking at the actual bed's angle. And what I mean by that is the little ball that's in the side rails. Assess for extubation. So yet again, going back to every intervention, you want to remove that intervention. So we're going to do tests to see if we can extubate this patient, see if they can spontaneously breathe themselves, and if we even need this intervention at all anymore. And then also giving histamine 2 blockers. These can help out a lot with these can help out a lot with the like gastric ulcers and also like get with secretions within the respiratory system. Okay. Um, Nosin. Nosin actually came about during COVID, and it's actually because of patients who are on ventilators. Okay, so um, COVID lives within our nasopharyngeal cavities here. So if we ventilate a patient through an ET tube or a trachea, what's going to happen is that patient stops breathing through their nasal cavity, and the COVID will go dormant, and it won't be cause the patient to be symptomatic anymore. But as soon as this patient returns to breathing spontaneously at their own will and through their nose, those COVID infections were actually resurging again, making the patient symptomatic and having to be placed back on ventilators. So Nosin was actually created to kind of sanitize the nose so that when the patient was extubated or put in a position to breathe again, we didn't have a resurgence of COVID. Uh, Ventilation weaning. This is not something I'm super familiar with, so I did have to do quite a bit of research on this. Most of my patients were going on a vent or were transported with a vent, so vent weaning is something I'm not super familiar with. So we'll talk a little bit about it. I'd recommend doing your own research, but I tried to go pretty thorough. Um, so the biggest thing is if you delay weaning, it actually makes the patient less likely to have positive outcomes. So we have increased morbidity, increased mortality, an increase in length of stay, and increased risk of long-term care. Okay, so if we delay it, the harder the patient's going to have coming off of it. 42% of patient time is from weaning. Okay, so that means that like 58% of the patient's time is going to be on the ventilator, and the rest of the time is going to be getting the patient off of the vent. It takes a very long time, nearly most of the time is getting off the vent. Okay. And complications can occur from delayed weaning if they have comorbidities, things like CHF, COPD, um, asthma, stuff like that can all lead to complications to ventilator weaning. Okay. So when we're removing a patient off of the vent, we're going to be assessing for respiratory insufficiency. So if a patient's being removed off a vent and they start desatting or they're just not getting enough volume or pressure in negative pressure to properly perfuse the body, we wouldn't be able to wean this patient off. And then if we also have a reduced ventilatory capacity, such as the diaphragm is weak and atrophied, we want to make sure that we slowly wean this patient off or kind of maintain at a certain pressure or volume until the musculature comes back. Okay. The atrophy can be caused from a couple of things. We could have the steroids that we give them, the corticosteroids, these sedatives, the paralytics, and also inflammation. So if they were infectious in nature or they got a ventilator acquired pneumonia, these can all weaken those thoracic muscles. Uh, what's interesting is that this actually puts us in a paradox. Okay, so if the patient's on a vent and we try to wean them off the vent and then they can't, they only meet to a certain point. They need to stay on that vent longer, which means we put them back on the vent and then they just keep getting weaker. So it's kind of a weird paradox here where at what point do we say enough's enough and just start bringing this patient off even if they come and become a distress and think of alternatives. So it's a really weird issue that we encounter. Okay. So that goes a little bit into respiratory insufficiency. Next, we have a cardiovascular insufficiency. So with cardiovascular insufficiency, like I said, that's kind of one of the complications for comorbidity is going to be heart failure. So if a patient has heart failure, they're not going to have, when we reintroduce this interthoracic pressure from the patient ventilating themselves, so we have that diaphragm and those interthoracic muscles contracting and expanding, we're actually putting pressure on the major vessels, and we're also increasing the pulmonary artery resistance. So we need more pressure from the right ventricle to push pressure into the lungs. And what can happen is this pressure that is required on the heart creates a demand on the heart. We can get what's called the demand ischemia. So we can actually have cellular death of those cardiac myocytes because of the interthoracic pressure that has increased. So kind of a weird paradox, and same thing as before. As this patient's been on a ventilator, if they have heart failure, and we stop that, we reduce that pulmonary artery pressure, we're going to have a little bit of an atrophy of the heart muscle as well. So, as we increase the resistance, maybe that heart can't meet the perfusion needs of everything else. So, when that's where the demand ischemia comes on, so we can have heart death because of this. So, some weaning techniques. I looked up like an NCBI article about how to do a proper trial. It's very in depth and it looks to be more at a provider level as far as performing the assessment. So we have a spontaneous breathing trial. So if the patient is able to breathe for 30 minutes spontaneously by themselves, this would be a good time to successfully perform ventilator weaning. And then they can also perform what's called a cuff leak test. And this is used to check for patency of the airway. So if we deflate the balloon that is on the lower portion to block the esophageal gap up into the larynx, um, we're going to deflate that and we're going to see if the patient can actually maintain patency of their airway while doing the spontaneously breathing test for 30 minutes. So we're assessing, yet again, ABCs. We're assessing A and B in this, okay? And then there's the next trial would be extubation to non-invasive ventilation. So we're going to gradually reduce the pressure support and then move off of an ET tube to maintain airway to something like a V60 mask or a Venturi mask, or some sort of mask that goes on the patient, or maybe something that hooks up to a trach collar. Next, we're going to go to the pulmonary embolism topic. Okay, so we should all be pretty familiar with pulmonary embolisms. These are pretty life-threatening. Um, they happen very commonly, and I feel like everyone here should be very confident in identifying and being able to treat or know the treatment plan for a pulmonary embolism. Okay, so a pulmonary embolism is an obstruction of pulmonary vasculature. Okay, the common cause of a PE is going to be DVT. There are some rare cases of being an air embolism or a part of a tumor breaking off and causing a embolism, and also we could have particulate from injections or surgery. So if we go in with the surgery and let's say like we have some sort of like perforated gauze that they're using or part of the sponge, and it breaks off and somehow ends up its way into an artery, that can be thrown into the lungs, and now you have a PE. So they are quite rare, but the most common cause is going to be from a deep vein thrombosis. Some cause, I wrote, so some of the causes here. Sorry, I was trying to figure out what I was trying to say here. Um, so loss of lung tissue, pulmonary infarct, cardiac dysfunction, heart failure, and death. This is what a PE can cause. Not sorry, it's not what causes a PE, but what can happen because of PE. So we can have loss of uh, an entire lobe or an entire section of a lobe. We can have an infarct of the actual blood supply that's actually feeding the lung. We can have dysfunction of the heart. So, because of this demand ischemia, we can actually have heart failure, or we can actually put the patient into an arrhythmia or dysrhythmia. And of course, we can have death. I have seen people die from PEs. It happens quick and in a hurry, so just make sure we're really aware that PEs can happen to anyone. Okay. Typically, we can see here it's caused by right ventricular failure, so the afterload, and that's kind of what I was talking about earlier. I drew a little bit of diagram. I am not by any means an artist, so we have the right atrium, the right ventricle, left atrium. So this would be the right lung. So we can see here we have the superior vena cava, inferior vena cava. So the blood flows in, goes down through the tricuspid valve into the right ventricle. And this right ventricle is what's forcing the blood through the pulmonary artery into the arterioles, okay, that go around the alveoli. So what happens here, this is the pulmonary artery here, and these break off into smaller and smaller vessels. And if we have a blockage here, and the heart is pumping and trying to push against this embolism here, that pressure is going to go way, way high. All right, that pressure in that pulmonary artery is going to be super, super high. And what can happen is this right ventricle is trying to beat that resistance. It's trying to push against it. And the right ventricle is the weakest of the two ventricles because it usually doesn't it only has the pulmonary pressure. It doesn't have the systemic pressure like the left ventricle. So due to this demand, this afterload pressure that it's having to push against, we can actually have failure of it and cause ischemia in that, and we can actually put the patient into a myocardial infarction. Okay. And like I said, they're actually pretty common. 1 in 1,000 people will have a pulmonary embolism. So, like I said, just be available to identify pulmonary embolisms quickly and be able to notify the provider that we need to start treatment for it. Okay. Risk factors. When we're looking at risk factors, I wrote some generalized terms and kind of broke it down a little bit. So, venous stasis, so the stasis of venous blood flow. Vascular endothelial defect injury. So the cells die within the vascular endothelium. So within a vein, if something happens to one of the cells, they might die and it's going to cause an immune response. And some of that particulate can cause a response of platelets, or because if we have a rupture because of this trauma or injury that affects, it can cause an immune response, and then part of that immune response can break off and cause an embolus as well, and then hypercoagulopathy. I definitely slaughtered that. So if we're looking at it, immobilization, paralysis, AFib, a little bit of AFib. So if we just have blood that's just sitting here because we don't have an organized rhythm, it's an arrhythmia, dysrhythmia. Okay, so we don't have any organization, blood flow. The blood's just going to coagulate within the atrium, and let's say a little bit of that coagulation goes into the ventricle, and that ventricle pushes it out into the lungs. Well, we just threw a clot that our heart made into the lung. Pregnancy, when we're pregnant, we have a heightened immune response, so our body is more readily available. And then also the placental and uteral membrane has a high risk of creating clots as well. There's a different permutations that can occur from pregnancy. Obesity. Uh, let's think about why is this person obese? Well, they probably have a lot of cholesterol or many other things within their bloodstream, so that's going to be a high risk. A central line or a femoral line. Anytime we're introducing something into a bloodstream, there's always risk of increased coagulation around that. So patients of a higher age will have a change in their immune response and a change in their coagulopathy. So just make sure we keep an eye out for that. Tobacco, nicotine. Nicotine is a vasoconstrictor. So for closing down those vessels, and let's say that a clot forms because of that vasoconstriction, puts us at risk. Trauma or injury, yet again, if we bump our leg really, really hard, there's a possibility that we can create a clot in the lower leg and the body just doesn't respond well. And then cancer, cancer cells can break off. That's how we get like metastatic cancer or metastasize. So this cancer pieces can break off, and if it makes it to the heart and lungs, that's how we can develop a PE. Prevention, and if we're already an inpatient or if we're at like home health, there's a possibility we could put them on SCDs or sequential compression devices, which are those little socks that go around the calves. There are also ones that go up into the femoral area as well, so full sleeves as well. So those are possibilities. And then pharmacology. So we have some sort of medications that can change the properties of coagulation so we are not so hypercoagulopathic, but maybe normal or hypocoagulopathic. And then early ambulations. Anytime a patient has surgery or is in hospital, we want to make sure we get them up and out of bed as soon as possible to get that blood moving. The sooner we get them up out of bed, we decrease their risk of DVTs and therefore increase the likelihood of recovery without complications. Signs and symptoms can be difficult. They are most commonly they're non-specific and they can be asymptomatic or vague. Okay, so they might have really random things that are occurring in them. There is no black and white in this. This is all going to be gray. But some symptoms you can experience, let's think it's affecting the heart and lungs. Okay, so we can have dyspnea, tachypnea, tachycardia, chest pain, cough, hypoxemia, and hypotension. So these all have to do with the heart and lungs. Okay, so just keep these in mind. Anytime you see chest pain, those are you automatically need to be thinking heart and lungs. Okay, so let's go and get an EKG and see if we can find anything. If that's not that, we're going to move on to our differential diagnosis. So anytime you're thinking PE, you should also be, like I said, heart and lungs. So we've got pulmonary edema, acute myocardial infarction, so some sort of heart attack, ARDS, acute respiratory distress syndrome, or cardiogenic shock. All right. To diagnose a PE, we're going to be looking for a D dimer. I want to talk about this a little bit real quick. So D dimers, providers are kind of changing their thought process on how to use D dimers within the past 5 years. D dimers are highly sensitive and non-specific. So what that means is that they're very good at detecting whether D dimer is detected within the blood, but it does not mean that they're experiencing a PE or a DVT. It could mean really anything. A lot of times, patients who have a positive D dimer, their studies come back unremarkable, even with MRI and CTs. So just keep that in mind. A positive D dimer, typically, depending on the lab equipment, especially if you're familiar with lab equipment, on a triage meter, is going to be 500, greater than 500 nanograms per milliliter. Our best way for a definitive diagnosis is going to be a CT angiogram. So a CTA, depending on your facility, make sure we have a 20 gauge or larger IV within the AC forearm or higher. Just so this has to do with the timing of contrast being injected in needs to be timed correctly for the scan to pick it up within the heart and lungs. It's very specific, very timed. So just make sure we have a large bore IV. Check for allergies for the patient to make sure that they don't have any allergies to contrast, and also rule out that they're not pregnant. We can also do a magnetic resonance angiogram. It's the same thing as a CT scan, just using a higher level of radiographic imaging. So MRI is always going to be the best way. Okay. Um, interesting things I was reading is that a CT is actually preferred over magnetic resonance for diagnosing a PE. I'm gonna have to study that a little bit more to figure out why. Um, Rarely and non-definitive, we could also do a VQ scan. Usually that'll be done with the cards or RT. Okay. Something I want to talk about to get you thinking more like a provider is there's actually something that seasoned MDs and DOs are allowed to use to diagnose PEs with a higher accuracy than a CTA. Okay, and this is called the pulmonary embolism rule out criteria. Okay, so basically they have this calculator, and you can see we have a bunch of factors. So age greater than 50, heart rate greater than 100, OT stats less than 95%, unilateral leg swelling or edema, hemoptysis, previous surgery or trauma within the less than 4 weeks? Have they had a PE or DVT before? And do they use hormone use such as estrogen or birth control? Basically, you go down. It's a no yes question. No earns you 0 points, and yes earns you 1 point. Based off of this grading scale here, they can rule out, not rule in, but rule out a DVT. So it's very interesting. Like I said, only seasoned providers are allowed to use this without liability or litigation. So, but it allows you to think, what is a provider looking for? So if they have any of these risk factors here, you might want to be thinking that they might be having a DVT, or sorry, a DVT or a PE. My apologies. Treatment. We're doing with the heart and lungs. So O2, fluids. Okay, so we want to make sure we're properly perfusing this patient and we're increasing their blood pressure. One of the signs and symptoms can be hypotension, and that has to do with the effects of the heart. We can have that demand ischemia and not have proper perfusion. So, yet again, vasopressors kind of goes hand in hand with the fluids. Anticoagulants. So, in this case, we're going to use heparin. I should specify that we're going to use low molecular weight heparin. These are going to be administered to help prevent further incidence of any enlarging of that clot, okay, that embolism. Higher level of care, so these are going to be surgical interventions, not something we can typically do. I've seen weirder things. We could do a catheter assisted thromboectomy, so removal of that embolism and embolectomy through, usually what they'll do is they'll go in through the femoral artery or the brachial artery, go in through the vena cava, in through the heart, through the pulmonary artery, into the lung, and remove out that embolism. Or we could put a IVC filter, so inferior vena cava filter, so we're preventing embolisms from coming up through the vena cava, so from the lower extremity up into the heart, so it's just filtering that out. Okay. Um, the IVC filter here requires long-term management, so they're going to have it reevaluated if they have a lot of particulate and they start having issues. They might have to go and have that IVC filter cleaned out. Okay. So next we're getting into cardiac. I've started this. I'm going to have to take a break here in a minute, and I'll do another section on life-threatening arrhythmias. I kind of just started out a little bit here, okay? I highly, highly recommend everyone check out this website here. So litfl.com, lifeinthefastlane.com. This is a website that's designed for EMS providers at the paramedic level or EMT intermediate or advanced for doing ECG recognition. This is actually also a resource that MDs and DOs, PAs, NPs all use to do a little bit of refresher. It can get very in depth, but it also remains very basic. So I highly recommend everyone take this out if you feel unfamiliar with looking at different rhythms and arrhythmias. Okay. So first, we're going to talk about the different waveforms. So we can see here we have a P wave, Q, R, S. We have a J wave, a T, and a U. As a basic provider, we're going to be focused on P, Q, R, S, T. All right. We can see here we have a PR interview, an RR interview. Just remember, our RR interval is actually what's dictating our heart rate. And then we also have a Q2 interval. So there's a bunch of different segments here. Another big one is ST segment, and we will cover that a little bit here in a minute, okay? This first one, I want everyone to look at it here. Just take a second. I'm going to pause for about 5 to 10 seconds here and see if you can figure out what this one is. Well, if you couldn't find anything because there's nothing to find, that is sinus rhythm. That is a completely normal rhythm. That is what we want all of our patients to look like in some sort of form. Okay, so that is a perfect waveform. Let's go in through and check here. We've got we've got P, Q, R, S, T, 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 P, Q, R, S, T. You can see we have all of our P, Q, R, S, Ts, and we can see, let's look at the intervals here. They look initially to be quite normal. I can't really put up a ruler or a piece of paper here to mark them out, but they look to be in a regular intervals here. So this would be good. Okay. Looking at this one, what do we think we got going on here? I did choose kind of a tricky one. So this is sinus tachycardia, okay? I know this looks like a lot of noise in here, and I chose this one on purpose to show you that sinus tachycardia, what's happening is since this heart rate is beating so fast, there's a lot of electrical activity. And usually when someone has sinus tachycardia, they might also be breathing really fast as well. So we can have a lot of different artifacts showing up on this sinus tachycardia rhythm strip. So just bear that in mind. But if we're looking at it, we can see we do have a notable P wave on all of these QRS waveforms. They're at a regular interval, and we can kind of see T waves popping in here, okay? But like I said, there's a lot of artifacts on this, but this would be sinus tachycardia. If you want a textbook example, just imagine this sinus rhythm here, just more squished and more of them. Causes of sinus tachycardia, we're going to have hyperthyroidism, sepsis, acidemia, cardiac tamponade, or different medications. Also, a common cause of sinus tachycardia, exercise, stress, anything that can drive your heart rate up, anxiety. These are all examples of things that can cause sinus tachycardia. Looking at this one, looking at the rhythm strip here, let's see. So in this segment here in lead one, we only have 1, 2 QRSs. That doesn't seem right. Well, that's because this is sinus bradycardia. We know it's sinus. If we zoom in here, we can see it's the voltage is a little low here, but let's look at lead 2. We have P, QRS, and this is either a T or a U wave. I'm going to go with this as a T wave. So we have atrial dipole. Oh, we'll go back to that. We have P, QRS, T, so we have everything we need here, okay? While I'm thinking about it, let's go back and talk about what these different waveforms mean. Sorry, I forgot. So P is going to be our atrial depolarization. So this is the depolarization of the atriums, which means we're having atrial contraction. Okay. Next waveform complex we have here is the QRS. QRS is ventricular depolarization. So these are the ventricles contracting. Next, we're going to have the T wave. The T wave represents ventricular repolarization. So these are the ventricles relaxing. Okay. Now you're going to ask yourself, well, I said we have a depolarization, depolarization, repolarization. Well, where's the atrial repolarization? Atrial repolarization is typically going to be masked by the QRS complex. And the reason being is because when we're measuring this electrical activity, the highest millivolt that we read off of this EKG is going to be the one that is recorded. So the atriums are much smaller and repolarization is much smaller. Let's look at the QRS compared to the T. So depolarization versus repolarization. We're having a lesser change of millivoltage. So therefore we are masking the atrial repolarization, which is much more minuscule compared to the depolarization. So it's going to be under here. Okay. The U wave, I'll talk a little, I can talk about this for a couple seconds. Long story short, we actually don't have an exact understanding of what the U wave represents. All we know is that the T and the U wave should match direction, so we'll call it axis. So see how the T wave leans from left to right? The U wave is leaning left to right in a slight angle here. So when we're talking about U waves, they theorize that it represents the repolarization of the Purkinje fibers or the bundle of His. That's a theory. It has not been proven yet. Sorry about that little interlude. We're going to come back to the bradycardia section here. Some common causes of normal sinus bradycardia is going to be sleeping. So our heart rate will decrease just a save energy and due to the decrease in metabolic needs, we're going to have a decrease in heart rate, and that's due to the parasympathetic nervous system. We can also have it due to increase. I wrote fatal tone. I meant to write vagal tone. So remember the vagus nerve. The vagal tone is the parasympathetic nervous system, which is going to decrease our heart rate. Yet again, I wrote fatal. My apologies. Like I said, didn't have enough time to get this proper. Vagal stimulation. Yet again, going back to this. So if someone's going number 2 on the toilet, their heart rate might go down, or if they're having a lot of pain, their heart rate might go down. This can cause a syncope episode as well due to the decreased perfusion to the brain. We can have an inferior myocardial infarction, so inferior being the back of the heart. So we can have a myocardial infarction in that portion there. That can also drive down the heart rate. We can have a disease of the sinus node, so the sinoatrial node. So that is our pacemaker. Remember, the autonomic pacing of the sinoatrial node is going to be about 60 beats per minute. So if we're lower than that, it might mean we went to a secondary mode, or the AV node, which is approximately 50 beats per minute. And if we go down to the bundle His is 40, and the Purkinje fibers is 30. So depending on the rate, we might have some sort of issue with one of our nodes. Hypothyroidism, hypo, low, so low heart rate. Remember, we're doing hypothyroidism. We're changing the amount of calcium, which is one of our ions that are responsible for helping with repolarization and depolarization. We could have anorexia nervosa. So we're shifting potassium due to many different factors. Yet again, electrolyte imbalance. If we have a change in potassium, sodium, chloride, any of these electrolytes here, we can have a change in the cardiac myocyte activity. Hyper-K, hypermag, that can also affect it, and myocarditis. Okay, so medications to look out for if they're taking some of these medications, or if you're at if you are bradycardic, you might not want to give any of these because it's going to drive the heart rate even further. Beta blockers, calcium channel blockers, digoxin, central alpha 2 agonists. Okay, so alpha 2, remember going back, we're talking about, let's just find our little diagram here. Alpha, artery smooth muscle, 2, dilate. Okay, so let's just keep that in mind. Opioids, benzos, and organophosphate poisoning. Okay, so these are all things that can affect and drive the heart rate down. If a patient is unstable and symptomatic due to their bradycardia, how can we treat it? We'll skip over pharmacological methods. Let's think of what interventions we can use, specifically on a monitor. Keep thinking, keep thinking. Edison. Yep, we're going to use pacing. So we're going to pace the patient, okay? The good way to remember pacing, if you've ever gone for a run before, if you were ever in the military, if you run a little slow on your test, or you just want to run a little bit faster, or if you're running the Olympics, you're going to want a pacer to set the pace for you. So you want to run faster, you want your heart to beat faster, so we're going to set the rate for you. We're going to say how fast you're going no matter what, okay? So go and put some pads on the patient, crank it up to whatever rate you want to. Typically, you start from least evasive to most evasive. So we're going to start at the standard rate of 60 beats per minute. If the patient has decrease in symptoms and the patient increases in perfusion, we'll leave it at 60. If the patient is not perfusing and the patient is still symptomatic, we'll crank that rate up until we titrate it to an effective rate that meets the patient's demands. Okay. Next, we have atrial fibrillation and atrial flutter. Okay, so when we're looking at atrial fibrillation here, this top strip, if we're looking in here, we're looking at the atriums. And remember, the atriums are represented by the P waves. So when we're looking in here, we can see our P waves kind of look like they're just kind of all over the place. We have no organization of these P waves. They are just kind of fibrillating. Okay, they're not fluttering, they're fibrillating. They are not organized by any means. We can say that there is definitively no movement of blood flow or minimal movement of blood flow within the atrium. So this is a non-stable, this might be a unstable dysfunction. Okay, Patients with AFib can be stable only for a diffuse amount of time, okay? So just make sure you're assessing your patient if you see AFib on a monitor. AFib is also one of the most common different types of cardiac dysfunction. So make sure we're always assessing our patient, figure out if they've been seen before, what are they taking, what works for them, find out who their cardiologists are, what medications are they taking, and do they have some sort of pacer, implanted or external pacer in place to help correct this. Some common causes of AFib could be an ischemic heart disease. So we've had cardiac death in some section here that's causing the atriums to quiver. We can have hypertension, a valvular disease, so either the tricuspid, bicuspid slash mitral, or we can have some sort of like aortic valve dysfunction. Okay, so these can cause AFib. Infections can also affect the cardiac myocytes as well, so we need to make sure we're looking for infection. And then hypo-K, hypomag, different types of medications, drugs, and ETOH. These can all cause it. We also have PE, pH disturbances, so disbalance of homeostasis, cardiomyopathy, and pheochromocytemia, so cytoma, sorry. This is basically just a tumor in the adrenal glands of the kidney, okay? Now when we're looking at atrial flutter, we can actually see that these P complexes, we'll call them, P complexes here, have organization. They all look pretty much the same with limited deviation. Um, and so this is kind of more organized, okay? When we're talking about these, we can see we have an atrial to ventricular blocks, and these set the rate, okay? So if we're looking in here, we can have a 2-to-1 pattern. I'm going to scroll into my awesome drawings I made here. We can see we have two P complexes to one ventricular QRS complex, so 2-to-1. So we can estimate the heart rate is going to be about 150. If we're at 3 of them to 1, we're about 100, and then 4-to-1, we're at 75. These are the most common, 2, 3, 4. And we can see if we look in our EKG here, or a little strip. If we're looking over here, we can see we have 1, 2, 3, 4, 1. And then we have 1, 1, 2, 1, 1, 2, 3, 4, 1, 1, 2. I call that 3-to-1, 2-to-1, 2-to-1, maybe 3. So we can see we can have variation, but it could also be at a set rate of just the 3-to-1 the entire time. So there is the possibility for variation, or it can be the regular. Okay. Please note that this is a form of SVT, supraventricular tachycardia. So what's happening is that the atrium, that's a lot of atrial waves here, okay? So if the ventricular rate is somewhere 75, so let's use this one example. If we're having 2 atrial contractions to 1 ventricular, okay, so our ventricular rate is 150, but our atriums are doing twice the amount of contractions per 1 ventricular rate, okay? So if we do 2 times 150, we're going to get a rate of 300. Same thing here, 3-to-1, 300, 4-to-1. Okay, so we're having a very, very rapid rate here in the atriums. Okay, so we're having atrial tachycardia, so it's going to be SAT, sinus atrial tachycardia. The ventriculate is going to be slower due to the AV block. Okay, and so what I mean by that is that when we're doing with conduction here, if we're having a P wave, we should have a QRS right after it. So we have some sort of atrioventricular, so that lower node before the bundle of His is blocked for some reason, and we're not having a QRS complex after it. This could be the etiology, so the reason it's happening, or it could be a side effect of the atrial flutter. Okay. Some treatment methods we could do, since this is SVT, we could try vagal maneuvers. So it's kind of be the same as SVT. We're going to vagal the patient, try to stimulate that parasympathetic system. Or we could give adenosine, which is a potassium channel blocker. So we're just going to stop and restart the heart for a brief period of time. Okay. Next up, what do we got going on over here? So let's take a look here. We can see we have something highlighted here. So we have P, QRST, P, QRST, P, QRST. But we can highlight here that we have an increase in the PR interval. Okay. So where there's a longer period of time from the SA node stimulating the AV node. So we have a higher period of time from the atriums stimulating the ventricles to contract. So this would be a first degree heart block, okay? And this is defined by a PR interval greater than 200 milliseconds. Okay, so if we have a PR interval greater than 200 milliseconds, or we have a increase in the length, or a widening increase in length of the PR interval from the from the P to the QRS wave, this is going to be a first degree heart block. This is usually a stable rhythm. Um, Usually asymptomatic. They might experience an occasion of chest pain, but this is usually caused by disturbances of cardiac health. Next up, let's look at this one. All right, so we've got PQRST, 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 P. Wait a minute, P. There should be QRS here, PQRST. Interesting. So we've got, and if we look at the length of time here, we can see that these PR intervals are actually getting longer. So we've got longer, 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 drop. Now we have a Winkenbach. This is a type 2 or a Mobitz 2 heart block. So this is going to be one of our type 2 heart blocks, okay? So we have a partial, so this is a delay in conduction. This is a partial loss in conduction in the cardiac myocytes here. So we have a partial loss. We're losing waveforms here due to something going on with the conduction here. So the definition here is a malfunction of the AV node cells or fatigued cells. So cells, they get tired too, and they drop impulses. So they're just not pushing those impulses through down to the bundle of His into the Purkinje fibers. We can have a bundle branch block, or we could have it's made me think about it. You could have a bundle branch block, but this is beta blockers, calcium channel blockers, digoxin, amiodarone. Yet again, vagal tonicity, so how well that parasympathetic nerve is stimulating, an inferior myocardial infarction, myocarditis, surgery. And if you're symptomatic, we can administer atropine or we could start pacing. So we make sure we don't drop any of those beats. So I wanted to show you this over here. And if you've already identified what's going on here, well done, you've studied cardiology. If you haven't, that's okay. It takes with time and repetition. So first I want to talk about these blue boxes here. These represent the different locations of the heart. So we have lead 1 up here. This is representing a lateral portion. And if we look over here on the side, we have V5 and V6. This is another lateral portion. Okay, so these are our lateral leads. These represent the lateral portions of the heart. Over here, this section here, the little L in the bottom left, this is our inferior side. This is our inferior lead. So we're looking at the posterior of the heart. Okay. Or sorry, inferior, I should say, the lower portion of the heart. And up here, you can see that we have the superior leads or septal leads. Okay, so this block here. Looking in this section here, what do you see going on? Do these ST waves, this ST segment here, do they look okay? I would say no. This is actually a life-threatening injury here. This is a ST. It's elevated. We're definitely elevated over baseline here. So this is an ST elevated myocardial infarction in the inferior lead. So we're actually having a STEMI here. We need to get this patient to cath lab, cards. They need to come evaluate this patient quickly, okay? The reason I'm actually showing you this is because there is actually a heart block in here. I'll let you guys try and find it. If you can find it, good job. You guys see it? Awesome. Just a little critical thinking exercise for you guys. Come on, computer. All right, looking at this one here, you should probably, the arrows kind of give it away, but you should be able to notice it very, very quickly here. We have a P with no QRS, PQRS, 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 P missing QRS, PQRS, PQRS. Okay, but if we look at our P waves, we can see that they're happening at regular intervals. There's no changes and delays in the P waves. They're happening at regular intervals. We can look at our R to R waves. Besides the drop beats, they would be at regular intervals. So this is another type of type 2 block, okay? So just keep an eye out for this one. We're completely losing. There isn't a longer drop. Okay, this is just we're losing those QRS waveforms. Okay, this is another conduction issue below the AV node. Okay, so this isn't the AV node itself. This is below the AV node. Okay, so the bundle of His, the Purkinje fibers, we're having some sort of conduction issue that's not causing the ventricles to contract. So we're not getting those QRS complexes. It can be caused by structural damage, infarct, fibrosis, or necrosis. So something happening within those structures that I referred to previously that's causing a malfunction in the conduction. Okay, so they're still functioning, but just not all the time due to some sort of pathology. This is typically all or nothing. It's going to happen suddenly and unexpectedly. So it's just going to kind of start happening. It's not going to just happen every once in a while. It just happens. You're going to see it consistently. Okay. There could be no pattern. It could happen randomly. So P, maybe it dropped, and then maybe this one drops, and then we pick up again, and then drop. Okay, so there could be no pattern, or it could be stable. So we could have one dropped wave, 3 QRSs, one dropped wave, 3 QRSs, one dropped wave, 3 QRSs. Okay. Um, this can be unstable. Okay, so we could be symptomatic because of this because we're having bradycardia, the QRS. We're not actually pumping out enough blood to properly perfuse the total tissue. Okay. And this can lead to a complete block, so our third degree block. So this can be fatal, and the treatment is going to be permanent pacing for this patient. So we want to make sure that we don't allow them to drop any beats. Next up here we have, so if we've talked about type 1, we have our two type 2s. This is going to be our type 3. This is a complete block, okay? So we have a complete dissociation between the SA and the AV node. They are no longer getting along. There is no conduction between them. So what happens is the atriums and the ventricles are completely independent of each other. They are not getting along. They do not beat in accordance with each other. So the way to look at this is if we look at the P waves, they will happen at regular intervals. Okay, the P wave would be masked here. And if we look at the R waves, they are also happening at regular intervals. So we could have an atrial rate that is at a normal rate, and the ventricular rate could be at like 20. So we have a complete loss of conduction, okay? So if I said that our atrial rate is at 60, but our ventricular rate is at 30, where do you think the block might be? So if we're at 30, and if we remember the autonomic pacing of the atriums is going to be 60, the AV node for the ventricles is going to be 50. The bundle of His is going to be 40. So this means we have the bundle of His is actually initiating the ventricular contraction. So if we're at a ventricular rate of 30, so we have a loss in conduction between everything above the Purkinje fibers. Okay. So looking at the notes over here, complete dissociation of atrium and ventricles. This could be caused by cellular fatigue or conduction failure. The causes can be similar to above, inferior myocardial infarction, AV node blocking, so something's blocking the atrioventricular node. We can have be taking beta blockers, calcium channel blockers, digoxin. Okay, cardiac arrest is likely. This will not perfuse the patient. They will have organ failure and demand ischemia of the heart because the heart always feeds itself. So we can have cardiac death and we'll go into heart failure. We'll go into cardiac arrest. Okay. The treatment for this is going to be permanent pacing. We're going to have to go in and place a permanent pacer or an external pacer in this patient to make sure we can keep this heart rate going. Okay. Looking at this one, what do we got going on here? If you said SVT, you would be correct. This is supraventricular tachycardia. Okay, this can be life-threatening. This can happen randomly, or it can happen to a numerous amount of reasons. Okay, so when we're looking at this, um, the pathology is complex. I'm not going to have enough time to talk about this. If you're familiar with what re-entry is, this is going to be the main reason that we could have a cause for SVT is due to re-entry rhythms. Okay, so or re-entry conduction. So when we're looking at diagnosing this, we're going to be looking at the QRS complex. It should be narrow. It should be less than 120 milliseconds. So we can see we have narrow QRS waveforms here. And so this is going to be indicative of SVT. And we can also see we have intermediary rhythms in between here. Okay. So for supraventricular tachycardia, these patients can be stable or unstable or symptomatic versus asymptomatic. If you've taken ACLS before, you should be thinking this already of how to treat this patient. So if this patient is stable or asymptomatic, we're going to go from least evasive to most evasive. Okay, so when we're doing stable conversion, we're going to do a vagal maneuver. There's a couple different methods. The most common one is going to be to have the patient bear down, or you can have them blow out through a syringe for at least 10 seconds or as long as they possibly can. And sometimes I've actually never seen this before, but this actually can convert SVT back into a regular sinus tachycardia or sinus rhythm. The next level of care is going to be medications. So if we want to stop the cardiac myocytes from contracting for a brief period of time, we need to give a medication. If you said adenosine, you'd be correct. That is a potassium channel blocker. So we're going to stop the cardiac myocytes from intaking any potassium for a brief period of time. And basically, what that would look like is if you're looking at this QRSs, and all of a sudden it would be a hard rapid push followed by a flush because we want all that adenosine to get to the cardiac myocytes at the exact same time. And what's going to happen is you'll see this rhythm, and all of a sudden you'll see asystole or PEA for about 2-3 seconds, and you're sitting there staring at the rhythm strip. You're like, oh gosh, is she going to come back? Is she going to come back? And then boom, all of a sudden it picks right back up again. It may or may not work. They might go right back into SVT, or they might go into sinus tach, or they might go into sinus rhythm. If you are giving this medication or a patient has SVT, they need to be on pads because if we're giving adenosine or if they're in this rhythm, the likelihood that they go into not having a pulse and we need to start uh, our CPR is very, very high because this is a can be unsustainable, and we're also messing with the chemical activity of the heart. We want to make sure that we are ready to go and intervene if this comes to. Okay, so adenosine, and the doses are usually going to be 6 milligrams up to a max of 12 milligrams, just those two doses, so 6 and 12. Um, Usually in the ambulance, in a hospital, things can be a little bit different, but usually it's a dose of 6 and a dose of 12. Next up on our list would be a synchronized cardioversion. Okay, so synchronized means we're giving it at a synchronized time, matching the heart rate. Okay, so when you sync with the heart rate, you'll see little pacer marks marking out our QRS complexes here, and we're gonna press the shock button on the defibrillator basically with it synced up, and it's going to deliver a charge to the heart at a very precise time to put that patient back into rhythm. Okay, and like I said, we got to have pads on for this. I mean, if you're doing a synchronized cardioversion, you're going to have pads on already, but just make sure you're ready because there's a possibility that they might go into asystole or PEA or it's VFib VTAC. Okay, so just keep that in mind. Now, if a patient is symptomatic, we want to start from the most evasive. This patient is unstable and they are symptomatic. We need to get them out of this quickly because they're already life-threatening. We could have a decrease in blood pressure because they're not properly pumping out enough blood, or we can worry about demand ischemia if this heart rate's really rapid and we're not perfusing properly to these cardiac myocytes. We're going to have demand ischemia. We can start to have myocardial infarction. Okay, so just bear that in mind. Okay, so we need to do something quickly, and we're going to go from most evasive to least evasive in this one. Okay, so typically if you're unstable, you might start with synchronized cardioversion, and these patients would typically be unconscious, or they're just severely hypotensive. So we're going to just rapidly go into synchronized cardioversion with our defibrillator. And then if that doesn't work, we can try chemical. We can always try adenosine as well. Um, Normally, if a patient has SVT, they are going to go to cardiology. Some people just have it happen spontaneously, or patients, most often though, they'll have reoccurrence of this. So let's make sure we get this patient to the proper level of care. They're going to go up and visit cardiology and go get checked out, figure out the etiology or why this is happening, to make sure we don't happen doesn't happen again, and give them some long-term care methods. So recognizing that they're in SVT, some treatment methods. So you can always teach a patient to vagal at home until rescue arrives. And also maybe you can put them on some sort of medications or perform some sort of cardiac intervention via surgery. Okay. So I'm going to take a quick break here. I'm probably going to post the first half of this video together, and then I'll post the rest of the video going over the rest of the content.